Hello, everyone. I'd like to welcome you to our discussion today about the complexity of outpatient infusion billing and why you could be missing some revenue that you're entitled to. First, I want to give you a little bit of a background of the company I work for, medaptus, who we are. We have a purpose to enable healthcare organizations to focus on patient care, and we do that by innovating technology for organizations specifically in underserved and high value areas, of which outpatient infusion is one. We actually have three solution offerings at medaptus. Our flagship product is called Charge Pro, and it's a charge capture and reconciliation software that's been around for about 25 years now. We have a patient assignment software called Assign for inpatient rounding and hospitalist organizations. And what we're going to be talking a little bit about today, our Charge Infusion application and what that does. And that is an automated coding software for outpatient infusion charges. I'm the director of product management here at medaptus, where I played an essential role in the development of our Charge Infusion application. Today, I spearhead the product development for Charge Infusion, ensuring it continues to meet the needs of the evolving healthcare landscape. I have 30 years of experience within the revenue cycle, medical coding and software spaces, including 10 years leading revenue cycle and billing operations at Massachusetts General Hospital. My experience, I think, has given me a deep knowledge of coding, charge management, and billing requirements. Here at medaptus, we partner with organizations both large and small. Here's just a small sampling of some of our current clients. And I want to jump right into our agenda today and talk about what we're going to be discussing. And today we're going to be discussing the often overlooked specialized coding and billing requirements for outpatient infusion coding. Most organizations probably recognize the complexities of coding and billing for IV infusions in their cancer centers. But it's also important to realize that IV infusions occur across many outpatient departments, including the emergency department, observation care departments, and other specialized areas. While the services provided in those areas might not be as complex as in a cancer center, the billing requirements for those services must still adhere to the same exacting hierarchies and logic as those for chemotherapy services. So today we're going to cover why IV coding is much more complex than you might realize. We'll take a look at some common coding billing mistakes, look at the common strategies used by organizations to address those problems, and finally take a look at a new option that has become available in the last several years, automating IV coding directly from your existing documentation. So what's so different about outpatient infusion coding? What makes that special? First off, I should probably warn you here that this session is not going to be a thorough coding requirements review for outpatient infusion coding. If you'd like additional information about how to code specific scenarios, I'd be happy to help you out. And please feel free to use my contact information to get in touch with me, and I'd be happy to provide some additional resources or some feedback for you if that's what you're looking for. But since the coding for infusion services is determined by duration, type of drug that was infused, and route of administration, and some other factors, because it's essentially based on the duration of the infusion, that duration must be calculated to the minute. It differs from inpatient infusion coding, where infusion services are charged as part of the DRG inpatient prospective payment system, whereby organizations are reimbursed for all services provided during the inpatient stay as determined by that patient's diagnosis-related group, right? It is actually much more complex than that, but essentially the hospital is paid for all services during a patient stay, including drug administration through an IV line. That's what happens on the inpatient side. On the outpatient side, it's not a one CPT code for one service kind of a reimbursement model. Like I said, it's time-based, right? So the longer the infusion duration is, the more billable units you can charge. And then you have things like the hierarchy, and the initial codes differ based on the drug type and the duration given. So a long infusion, which is defined as anything 16 minutes or more, over it takes precedence over something called a push, which is under 16 minutes, or something that's injected directly into an IV line. If it's a chemo drug given, that takes precedence over a therapeutic drug, which takes precedence over a hydration drug. Additional infusions coded are all done so based on whatever you select as an initial code. And if you get the drug type wrong in any one of these scenarios, your billable units are likely going to be wrong, and not just your initial service. You're likely going to have your other billable codes incorrect as well. So why is it so complex? First and foremost, the billing codes that need to be generated for each outpatient IV service are based on the duration of the infusion and the type of drug that's infused. That's a different process than your typical billing, where you would have one CPT code for one service provided. Think something like an EKG, right? You submit 93010 to interpret an EKG, and that's the charge that the provider submits, and you get paid based on that. It doesn't matter how long the EKG lasts, right? These variables all require significant calculations to ensure accuracy, and that requires a lot of manual work for whoever is trying to figure out these billing codes, either coders, or in a lot of cases we see across many organizations, nurses trying to come up with those billing codes. And it really kind of depends on your workflow. Every charge needs to be created manually and reviewed against the documentation to be sure that the billing codes match the service accurately. If the documentation isn't accurate or not complete, the charge codes can be wrong or also incomplete. And lastly, we've already mentioned organizations often have nurses or other clinical staff creating these billing codes. And remember that nurses are not coders. They haven't been trained in coding. They don't want to do coding. And usually they don't have the sufficient training to be coders. But more importantly, it's more of a satisfaction thing. As I said, nurses don't want to do the coding, and to have nurses be responsible for billing codes kind of takes them out of their realm of expertise. They should be treating patients and dedicating their time to patient care and documentation rather than billing codes. So, in summary, IV coding is time-based, and it has to be to the minute. The difference between a 91-minute infusion and a 90-minute infusion can be an additional billable unit, for instance. So if you're off by 1 minute, that can affect your revenue. The longer the drug is infused, the more units that can be charged. And we've talked a little bit about the specific hierarchy: chemo drugs over therapeutic drugs over hydration drugs. Those designations are responsible for whichever code you submit as the initial code, from which all the other billable codes in the service are derived. Drugs infused at the same time or overlapping times have specific rules as well. If an IV is done via multiple sites, there are different rules for that. And as we all probably know, documentation can sometimes not be complete or even accurate. If you have nurses responsible for documenting and they're not documenting start and stop times exactly, and instead putting in things like 90 minutes, the difference between that and what the accurate duration might be could result in a lower reimbursement. So what we've seen with our data and why coding is so difficult on the outpatient infusion services, the rules and requirements for IV infusion mean that they take a long time to code. What we usually see is that simple infusions, where it's just 1 or 2 drugs only with no overlapping time or no chemotherapy drug, take about 5 minutes for a coder to create if they're coding directly from the documentation. That is for an experienced coder. Obviously, a new or a fresh coder is going to take a little bit longer. A more complex service with chemo codes, multiple pick lines, different sites of administration, et cetera, all these complications that figure into it will be twice that, or 10 minutes. So to solve any billing or coding problems that organizations may have, they really don't have a whole lot of choice but to assign more resources, assign more coders. So if you have a large volume of encounters daily, you're going to need a lot of coders to be able to code those. Even less ideal is to hand that off to your clinical staff to perform. In other words, say, well, your clinical staff, your nurses are the ones that know what the start and stop times are. So let's just train them to be coders as well. That's, as I said, not ideal. Just from a nurse satisfaction point of view, they don't want to do that. They don't have problems with checking off services that they performed. But once you start to get into kind of the complexities of infusion coding and the hierarchy and durations and how many minutes match up with how many units billed and what those codes are, that gets a little more complex and something that ends up being a point of contention among your nursing staff. So let's take a look at some common outpatient infusion coding situations that we've seen in some of our audits and what you might be doing that aligns with some of these problems. As I mentioned, outpatient infusion coding requires complex calculations, which are often not fully understood. Those billable codes that you have to calculate are based on the IV duration, requires accurate documentation of start and stop times and any event administration, drug administration event time. So if you have a paused and a restarted, that information has to be figured into the total duration of the infusion as well. And it's also based on drug types. So you have to have your clinical staff or whoever's capturing these charges understand what type of drug is being infused. Now, here at medaptus, we use NDC codes to determine the type of drug, and there are 18,000 different NDC codes. Now, if you're confident that your coders and your nurses understand each one of those 18,000 drugs and which one is a chemo and which one is the therapeutic and which one is a hydration service, then that's wonderful. But I'd ask you to probably look at that as a potential area for being able to be corrected. We also see overlapping times playing a crucial role in generating correct charges. If you have hydration going at the same time as any other drug being infused, you can't charge it. So even if it lasts for 4 hours, if it overlaps 2 hours with another case, you can only bill 2 units instead of billing 4. And so things to keep in mind that there's a very strict hierarchy here, right? If you deliver all 3 types of drugs, a chemotherapy, a therapeutic, and a hydration, which one do you select as the initial code? All the other codes for the service are going to be derived from that initial code. So you have to make sure that you're selecting the correct one. You have to have accurate start and stop times. It has to be to the minute. The difference of 1 minute from a short infusion to a long infusion could end up resulting in you getting paid $30 to $100 less for that specific service on any encounter. And as I mentioned, all the codes are driven by that initial service. If you get that wrong, chances are other codes on the encounter are going to be incorrect as well. So we've done quite a few audits of potential clients and actual clients in our travels here with our infusion application, and this is what we found in some of our audits. First of all, in 9 out of 10 of all organizations that we've seen, there were outpatient infusion coding errors. In other words, bills that were sent out that did not match the documentation in one way or another. We had one organization that we audited that had no coding errors. They had annually 30,000 encounters, and that's not a huge department. That's I would say on the small side, but they had 12 full-time coders who were coding every single one of those encounters by hand directly from the documentation and creating the charges from it. And they did a really good job on it. But again, you're paying 12 full-time coders to review 30,000 encounters, which is not all that efficient. Of the ones that had errors, the other 9 out of 10, the lowest error rate we saw was 35% of the encounters with errors. And the highest one we saw was 75% errors. And these, again, are things such as billable units calculated incorrectly or insufficiently. There were a substantial number of organizations that did not bill for their hydration services properly or at all. There was documentation missing for stop times, which resulted in lower charges being submitted. So we think there's probably a problem out there. And again, we've audited quite a few organizations and found this across the board for everybody. So if you know that you're having an issue in outpatient infusion, you're not alone. If you don't think you are having an issue in outpatient infusion, I suggest maybe you take a look at the data a little bit more just to make sure. Some of the errors that we saw that were very common were 10% of the KVO, keep vein open services, were incorrectly charged as hydration. And the reason for that is they're documented essentially as normal saline being given over the course of 6 hours. And if that's all the documentation you have in your EHR, it looks to a coder like that should be a hydration service. There are other factors involved in that, such as rate of administration for the hydration drug. But in 10% of all those KVO services, which shouldn't have been billed, they were billed as hydration. We saw 20% of all drug administrations with no documented stop times. Now, that can be that can be correct in a lot of cases if a drug is a given. In other words, if it's an injection, or if it's billed as listed as a push. If it's ordered as a push, there's stop times not required. But in these cases, at least half of those had a duration of more than 16 minutes, and they weren't recorded properly. And so that difference of 1 minute from 15 to 16 results in a longer infusion and therefore a higher reimbursement rate. So we think that's probably an issue as well. We saw also 40%, 4 out of 10 of all normal saline administrations in the ED and OBS departments that we looked at had no stop times documented. And you should be aware that if you have an ED, for instance, national average for emergency departments is about 35% of all patients who come into the ED have some sort of IV infusion. Because it's an outpatient department, those have to be charged in the outpatient infusion way, right, with the hierarchy and the duration of services being required. So of the 35% patients that you see in the ED, the patients you see in the ED, 35% of them are going to have some sort of hydration or infusion service, of which a lot of those are hydration. And if 40% of all those don't have stop times listed, you can't bill any of them, right? We did find at least half of those with a duration of more than 16 minutes. Now, in order to bill hydration, they have to have a duration of at least 31 minutes. So the data might be a little bit incomplete there, but still we think that is probably going to be a problem for a lot of organizations. So just to give you an example of how complex an infusion billing calculation is, this is an actual data set from an EHR showing one fairly complex infusion, right? And you can see on these line items, it's made a little bit easier to read. This is, an actual data extract. And you can see if you look to the far right a little bit, some things listed as new bag, stop, given, new bag. Those are events in an infusion. And as I mentioned earlier, you have to take into consideration all of the events for any drug given. And in this case, you have several drugs that are mixed together in a single bag. Off the top of my head, I can see fosaprepitant and sodium chloride. So fosaprepitant mixed in with normal saline is one drug order. You have vincristine in there, and also mixed with normal saline. And each one of those drugs that are infused and each event that takes place has to be calculated into your billable codes. And this is, as I said, it's a fairly complex infusion, but it's not an unusual one, right? And this would be obviously probably a cancer center infusion with all these chemotherapy drugs. But this is a listing of all the events that coders or your nurses have to take into consideration when they're actually trying to create the billable codes for their services. A single incorrect calculation anywhere in here could result in all of your billable codes being inaccurate. And that's kind of the point I'm trying to make. It's very complex. In addition to the drug names and types, you may see an NDC code in here as well. That's the numbers right here that have the dashes in between them. Those are NDC codes, and that's what we at medaptus use to identify what type of drug was infused. And you'll probably also see an order ID off to the far left, so that drugs that are mixed in the same bag can be accumulated together, because those can only be billed with one of the drugs that's in the bag. So you can see pretty quickly how complex this gets. And if you're not taking into consideration all of these events, then you might be doing it wrong. One of the big things that we see in our audits is a stop time not documented. And I talked a little bit about that happening, especially in the ED and the ops departments. If it's not documented for a chemo or a therapeutic drug, you could still charge a service, right? It gets charged as a push or a short infusion, but that's reimbursed at a lower rate. So the difference is about $30, regardless of whether it's a chemo or a therapeutic drug. But if you can build a longer infusion based on the duration of the drug administered, that's obviously going to end up giving you a little more revenue for that service, or the rightful revenue for that service, I should say. Hydration, hydration can't be billed as a push. So if you're missing a stop time on hydration, you lose out on all the revenue for that specific hydration service, right? If the duration is between 16 and 31 minutes, you can't bill it anyway, so that it's irrelevant. But if that duration of that hydration service lasts longer than 31 minutes, again, a difference of about $32 from what you're getting reimbursed to what you would be getting reimbursed if you didn't have that documented stop time. So it turns out that the difference between a short and a long infusion and a billable code is about $30 regardless of what the service is. So keep that in mind every time you're going through these. And if you're looking at your volume and you have a percentage of times that stop time has not been added or may not be accurate, and multiply that by $30, and that gives you kind of a quick idea of how much revenue you might be leaving on the table. Another issue that we often see, another common mistake, is selecting the wrong type of initial infusion. So remember the initial service, and that each encounter has to have an initial service, and it can only have one, right? It's not necessarily the first or the earliest IV that's done. That's a fairly common mistake as well. It should be determined by the reason for the service, according to CMS. Now, according to CMS also, regardless of the reason for the service, if you're delivering all three of these types of drugs, chemo, therapeutic, and hydration, you have to put the chemo service as the initial service. And likewise, if it's just a therapeutic and a hydration, you have to put the therapeutic service as the initial service. And oftentimes we see, well, the patient came in for hydration, and while they were here, they got an antibiotic, right? The antibiotic would be a therapeutic, and regardless of whether it's a long or a push, that has to be the initial service over the hydration service. And as I go through some of our clients and auditing some of their services, it's clear that the initial code can often be incorrect, and it's not really based on anything other than the knowledge of the coder. if they don't have an easy way to look up what that type of drug is, some of them can be confusing, right? CMS has what they call a HCPCS crosswalk, an NDC to HCPCS crosswalk, or an RX norm to HCPCS crosswalk. And we use the CMS HCPCS crosswalk to determine the type of drugs here with our system. And the bottom line, basically, it works like HCPCS codes that begin with J9 are typically chemotherapy drugs. So you would have to use the chemotherapy initial service. The hydration HCPCS codes, there's a handful of them, and virtually all hydration drugs, normal saline, potassium mixed in, lactated ringers, those things are hydration services codes, and there's a very specific list of HCPCS codes that address that. All the other HCPCS codes are considered therapeutic drugs with a couple of very small exceptions. And if your coders don't know all that, or they don't have an easy way to look that up, you could be having some issues with your coding. So manual coding requires users to know what that CMS designation of all the codes, regardless their generic or brand names, their HCPCS numbers, or even their NDC or RX norm codes, requires them to kind of know those automatically in their head. Same thing with your nurses. If your nurses don't have an easy way to look that up, and in most cases, nurses know, but new drugs are being added every day, and NDC codes get updated, every week. The crosswalk from CMS. So making sure you're up to date with those things is really important. We also see that there might be a tendency to round the duration calculation, right? If the duration is not accurate to the minute, if your duration calculation isn't accurate to the minute, the coding calculations are going to be inaccurate. And when I talk about rounding, it's interesting. I did a workflow analysis yesterday at a very large Northeast hospital here. And the nurses were responsible for creating the billing codes based on an electronic encounter form. Essentially, they would check off boxes, and their documentation consisted of writing down the duration and scanning it into their homegrown EHR system. So there were no values in the no value fields in the EHR for a start and stop time, but start and stop times were documented. But I asked the nurses specifically as they were checking off boxes, and they were invariably checking off the correct initial service in most cases. But I asked them, on the encounter form, it said units up to 90 minutes get this code. And I said, well, what happens if it's 91 minutes? And they, every single one of them I spoke to said, well, we would just leave it at 90 minutes and bill with one unit. And this is a very large hospital, a very large cancer center, relying on nurses to be able to do that head math, right? With essentially inaccurate start and stop times. They would write down start and stop times, but again, they would write them down that were matching what the orders were. The orders were essentially, infuse this drug over 90 minutes, right? And so they weren't paying attention to what the actual start and stop times were. They were just writing down the duration was 90 minutes. And so they would bill for 90 minutes, which is one billable unit. And if it was 91 minutes, they're eligible to bill an entirely new unit. And the reimbursement would have been about $60 more for each one of those encounters. So this goes on. We know this goes on. Defensive down coding is a thing, and nobody wants to say, well, I just figured it was close enough, right? But that, again, if that's happening, there's substantial revenue that you're probably leaving on the table. For instance, one of the first audits we ever did, we had a large cancer center, and they had more than 150,000 infusion appointments annually. And they had nurses recording the start and stop times and creating the billable charges, the billable charge units from those start and stop times using their own head math. However, they were trained when they joined and started working in this cancer center to always round down to the nearest 15 minutes to the hour. So if an infusion lasted 16 minutes, they would round down to 15. If it lasted 32, they would round down to 30. 47, they would round down to 45. And they realized very quickly after starting using kind of this automated infusion charge capture that they were missing an awful lot of revenue. We changed the workflow a little bit. We implemented some automation in there, and the billable unit, we found the billable units created from the actual start and stop times ended up that organization within a year saw an increase of $4.6 million. That's just in 12 months, $4.6 million, same volume. So it can definitely have a drastic impact on your reimbursement. So I would encourage everybody to take a look at how your infusion coding is being done, just to see if maybe a similar thing applies. In the case of the audit I did yesterday, I had asked the nurses, you know, were you trained on this when you joined? And they said, well, yeah, somebody told us what to do. But they didn't have any kind of training in place every year to make sure that it was being done accurately. So anything that carried over from 10 years ago, for instance, that a nurse was doing was kind of still applied today. So again, common mistakes that are made that are going to cost your organization revenue. Lastly, and this is a really good chance, a very good chance your coders and nurses might not be charging overlapping or concurrent infusions accurately. The rules are very specific about overlapping time and concurrent drugs being infused. So typically we see inappropriate charging for IVs with overlapping time, especially in the hydration area. It's not billable if it's concurrent with any other IV drug administration. If you have hydration running at the same time as a chemotherapy drug, the hydration service is not billable. You have to remove that duration that it overlapped from your unit calculation. And that can lead to overcharging of billable units. We don't typically see overcharging in a lot of our audits. Usually they don't bill for it at all. Organizations will say, well, if I can't easily figure out what the duration is during an overlapping thing, I'm just never going to bill it. And now, that's fine. You're not in any danger of a rack audit there, but you know, you are probably losing revenue also. And there's a very specific code for concurrent IV. If you have two therapeutic drugs running at the same time, for instance, there's one code that you can use for that. It's called concurrent. It's a concurrent CPT code. And it's based on the start time of the two infusions. And that can only be billed once per encounter, regardless of how long that overlapping is. So if you're billing it more than once, obviously that's incorrect. And if you're not billing it at all, again, incorrect and probably undercoded. So in summary, outpatient infusion coding requires specialized coding skills. It's one of the most complex coding scenarios that exists. And to be having your nurses perform it and having to throw coding resources at it because it's so complex is not an efficient way to do it. I mean, you have obviously incorrect calculations or documentation is going to drastically impact your revenue. And keep in mind that a difference of only 1 minute in your duration calculation is going to reduce your reimbursement or change your reimbursement. So we see many organizations investing heavily in personnel resources to address their coding issues for IV infusions. In many cases, nurses are still doing this. They're still responsible for trying to figure out what the infusion billing code should be for a particular encounter. It's a great dissatisfier for nurses. If you ask them, they hate doing it, right? And they really, you know, they haven't been trained to do it. They're not trained to be coders, and they don't want to be coders. They got into nursing to help patients. And that's what they want to be doing. So our advice is get them back to doing that. So how do we correct some of these IV coding issues that we see? How do organizations typically address these problems? Well, you'd be surprised to know that administrators often don't even understand how complex IV coding is, so they may not be aware of the difficulties involved with IV coding. A lot of administrators may have a background in coding or at least familiarity with coding, but it's usually something a little more basic than that. You know, the CPT code per service, right? They did an X-ray, that's the CPT code. We did a blood draw, that's the CPT code. And they may not be familiar with the fact that you have to have an initial service. You have to calculate the duration. If it's 91 minutes, it's an extra unit. So they may not be aware of it at all, right? And even with additional personnel, calculations are still performed manually, right? You still have to rely on head math. You're still going to have coders or nurses trying to calculate these codes out based on duration. So even experienced coders can make a math mistake, right? And those mistakes, the possibility for those mistakes is going to increase with the complexity and number of drugs that are administered and the number of events associated with those drugs administered. So remember, your revenue administrators may need to become aware of how difficult this coding is, and in order to be able to be convinced that there might be a problem there. And lastly, I'd like to mention that because of the complexity of these codes and because it's so difficult, and because, as we've seen, virtually every organization seems to have an issue with it, it's a favorite target of RAC auditors. It's so complex, it's easy to produce errors, accurate coding services. Doing it manually is just so time consuming and relies on human calculations that it's ripe for mistakes. And a lot of organizations are going to address those mistakes by undercoding all the time so they can survive a RAC audit. Again, not ideal, not efficient, and you may be losing out on revenue that you're rightfully entitled to. So there's a couple of options that you can do for correcting your IV coding. You can hire more coders, right? As I talked about earlier, that one organization that had 30,000 encounters per year had 12 coders. If you think about the number that they're doing a day, that's a very low number of coders. I mean, a very high number of coders perform a very low number of coding situations, right? If you're doing that, remember that depending on how your hospital or your workflow is set up, that complexity is going to increase even more for those encounters for things like crossing midnight, right? So each one of your billable units has to have the correct date of service associated with it. If the patient comes in to the ED at 11 o'clock at night and stays until 3 o'clock in the morning, and they're given a 4-hour infusion of even a hydration, that initial code is going to have a date of day 1, and 3 additional units have to have a date of the next day, right? Because that's when they were performed. So that adds some complexity to it. And again, depending on how your hospital is set up, if you have patients moving from one department to another, still receiving IV infusions, that's still considered one session. And if you're using CDM codes in the hospital and have to have different CDM codes for each department for those same services, how are those calculated out? How are those figured out? So again, depending on how your workflow is set up, these are some things that you have to keep in mind. And then there's the addition of, I would say, services that are often performed in infusion centers or places where infusions are performed quite often that are not specifically related to this IV infusion hierarchy requirements from CNS. And those are things like portable pumps or injections that aren't through the IV line, right? They're not a push, they're a sub-Q or a subderm or intramuscular injection. Those are often done in these areas, and those have to be calculated in as well, but they're not, as I said, not used in the IV hydration chemotherapeutic calculation. It's a little bit different, so those are handled a little bit differently. We would say, so we saw that one example of 30,000 encounters in the organization using 12 coders. In this manual way, we think they can be a little more efficient with that. For 30,000 encounters, you 4 to 5 coders to do it accurately and efficiently. So if you're 150,000 encounters, you're going to require 15 coders, or it was 25 coders, I'm sorry. So it doesn't scale very easily, right? If you want to expand your infusion services, you're required to hire more coders, but it's not an efficient scaling for that. And of course, it doesn't resolve your missing documentation issues. It doesn't, it still relies on coder performed calculations, right? And we know that human error still exists. You can't assure that the billing units match the documentation because there's no real good way to do a reconciliation between what the duration is in the EHR with what your billable units are. There's no printout there that says these are right. You have to review them all manually. requires huge expenditure of training, regular, yearly, or even bi-yearly, semi-yearly, every 6 months or so, whatever the word is for that. It requires regular training updates. You have to make sure that everyone understands any changes to the coding rules have to be permeated across your organization and across those responsible for creating these charges. And you have to make sure that they're updated with the right drug listings for determining chemotherapy versus therapeutic and that sort of stuff. And finally, one other thing to think about is kind of the lottery effect, right? What happens if you lose your most experienced coders because they got no pool together and they bought a lottery ticket and they won, right? How is that knowledge transfer happening? So you have to account for that as well. It's a huge expenditure and a huge training requirement for everybody involved. And just so you know, these are kind of the steps that a human goes through when they're doing these creating these codes in the billing system, right? They have to separate the medication out by category, by chemo, med, or hydration, so they know which drugs are which. They got to determine and code the primary service, the initial code, right? And then create the right additional hours of that billable code. If it lasted for 2 hours, you submit the initial, and then you submit the additional hours of same drug code. Then you have to code the initial sequential infusions, And by that, it means it's a different drug, but it's not the initial service. So I have to record a different CPT code for that and the additional hours of that drug as well. You have to code the IV pushes and the IV pushes that were given. You have to consider all the overlapping or concurrent time and code those appropriately. You have to identify and code any sub-Qs or IMs or outlier scenarios like a CAD pump or something like that were also given to the patient or provided for the patient. Then you have to combine all the same codes you just created and report and submit with the correct quantity of those units, or on separate line items that if that's what's required by the carrier. You have to make sure that CDM codes match up with those specific units if your organization uses CDM codes. You have to adjust the billing dates if the patient was crossing midnight for each one of those units that came through. And you have to consider and code additional services not noted above, like a prolonged infusion. It gets handled differently, right? And so something to keep in mind, if you have 5 full-time coders looking at 50,000 encounters per year, that's at approximately $60,000 per coder per year. And your number may obviously vary on that depending on where your hospital is located and what your workforce is. But still, for 50,000 infusion, that's going to cost you for 5 coders about $300,000 a year. Just keep that in mind as a figure moving forward. And obviously, if you're scaling up and you want to add 3 times that number of infusions, you're probably going to have to add 3 times the number of coders. Maybe you can get by with 2 times the number of coders, but still your expense is not scalable. There are some things you can do about it. You can correct your IV coding areas with a couple of steps. One is using smart pumps, right? So if you're not familiar with smart pumps and how they work, smart infusion pumps have essentially a computer brain where you can enter in patient information and it will automatically send that those start and stop times and any event documentation, any event documented directly into the patient EHR for that patient's service. And that's because that happens automatically and because the pump generates the data, you're kind of assured to have correct and accurate start and stop times for each one of those events, right? It'll record infusion drugs and event times directly into the patient's documentation. It'll allow you to automate a unit calculation from those recorded time events. So if you have those accurate start and stop type events, you don't have to worry about missing documentation. You can record accurate unit calculation from that, right? It can automate the assignment of the drug type. That's one of the great things about a smart pump and having a brain. You can preload in essentially this drug is this type, and so it can tell you exactly what type of drug it is. It can make sure that the unit calculation has the correct dates if it's over midnight, because it's going to give you a timestamp for each one of those events. So that's easy to do. can automatically calculate the correct departments if the patient moves simply by programming the pump. So and that allows you to have coders still, and you're still going to have coders do some of this stuff, but you can review kind of the exceptions, or if there's an error or something missing from any one of these pumps, coders can review that and then try to accurately get that documentation into the EHR as well. So combined with automation, if you're using smart pumps, you can calculate things 100% accurately to the documentation. And by that, I mean, if you're using smart pumps to populate your documentation for start and stop times and vent times and all that stuff, what you want to try to do is then automate those values to be able to create the unit calculations for the billable units. And you can do that. You can create a computer program that says, this is a chemo drug. It lasted for 91 minutes. That equals this code plus this code. And having that accurate infusion event times documented to the minute. And the programming provides accurate billable codes directly from documentation. So employing smart pumps and somehow working this automation of the information that smart pumps provide gives you full automation into your coding. Here at medaptus, what we've done is we have automated that process. Well, we don't deal with smart pumps, but we deal with the data from smart pumps. And what we've done is we've built a computer program that takes the data that's accurate in the documentation, and it calculates out the billing codes for every single one of those infusion events and gives you 100% compliant billing codes. And the way we do that was we have a little program that sits in your EHR, and it pulls out the data that we need for a patient infusion. Anytime a patient infusion service is done, it combines the drug identifiers via NDC codes to create a type, and it looks at the route of administration, and it looks at the duration for that particular drug, and it creates the billable codes for it. And it does this in a holistic sense for every single drug for that particular encounter, for that patient encounter. And the results have been terrific. It really speak for themselves, right? It reduces your administrative work, first of all, because you don't have to worry about it. You don't have nurses coding things, which is as we've talked about, a terrific dissatisfier. And it leverages your existing IT. It only requires a very minimal lift on the part of your IT team to put this little program in there and send us the data. And we've seen across the board, every time we implement it, it increases your revenue. You can develop this yourself. The coding for infusion outpatient services is very mathematical and it's very strict. So you can program it yourself. We did this about 4 years ago, and it took us a good year to make sure it was accurate. So we estimate that if you do this, you could be looking at about 2,500 IT or programming hours to get this done. And even then, you still have you have to remember that those NDC HCPCS crosswalks are updated almost weekly, and we update ours in our system every month to make sure we're accurately grabbing new codes. And if your CDM codes change at all, that has to be maintained as well. So there's an awful lot of maintenance involved with doing it, but it can certainly be done. If you already have the smart pumps in place, this can be done. And I do want to make it clear that as long as your documentation is accurate, regardless of whether or not you have smart pumps, you can still automate this part of it. As long as your documentation is accurate, no matter how that information gets put into your EHR, you can automate the coding part of it. Just to give you a little bit of an idea of what this looks like and what we found, we have Beth Israel Lahey Health up here in Massachusetts implemented our automated infusion charge capture, and they don't have smart pumps, by the way. They're still looking at getting them and making that process a little bit easier. But just using accurate documentation, they made sure that the nurses were documenting things appropriately. We have a little program that sits in there. In this case, it's Epic. Sits in their Epic system and sends us data every night. for the infusions that were done that day, and we calculate out the billing codes and essentially send them back to the Epic billing system after the codes have been calculated. And what we've seen is pretty amazing, right? Everything is 100% automated. So every time a patient has an infusion, we have an accurate charge for it. 90% of the charges that are created by our automated infusion system are billed without any kind of code or intervention whatsoever. In other words, there's no need for a coder to even look at it, or even a nurse to look at it. The codes are accurate. They reflect exactly what's in the documentation. The codes are created and we send back to the billing system. The other 10% of those that are reviewed or exception, or what we call our exception-based management, which we have. Beth Israel Leahy has a staff of 1 to 2 coders looking at that every day, as opposed to the 5 or the 10 that have done it historically. And usually those are things like couldn't identify the drug because it's a brand new NDC code, for instance, and it's not yet in the crosswalk. It's things like that. And our goal is to have 80% of the charges flowing through without any kind of code or intervention. But we've seen with essentially all of our clients that we've gone live with 95%, right? And this removed some substantial double documentation workflows that they had as well at Leahy. They found that they were documenting that when they had nurses essentially creating the billing codes, they would document all the errors the nurses made, and then at the end of the month they would send back a list to the nurses saying you did this wrong, and then expect it to work. So we eliminated a huge workflow for them as well. The compliance improvements, obviously, because these codes are generated by the data in the documentation, it's 100% compliant. There's never a discrepancy between the code that is charged versus what is documented. Just in terms of revenue integrity, obviously, all of their infusion charges are being charged. They never missed anything. And there was a substantial accelerated cash flow as a result of reducing their charge lag, because it runs through our system so quickly that it reduced their charge lag by 3 days, and that results in a kind of a bolus payment of additional revenue. So just to keep in mind, manual coding processes are super expensive and not very efficient. And they're not scalable, right? You can't just keep hiring coders. For one thing, coders are in short supply and high demand. So they're getting paid more and more, and the chances of you being able to fully man a coding department for you to meet your needs are getting lower and lower. And even still, errors are going to be common, and reconciliation with the documentation is impossible to maintain. There's no way to get it accurately. You're still relying on manual coder intervention. And although all of these calculations are complex, and it is a huge complexity to be able to automate this, they're also mathematical in nature and can be automated if done the right way. You can increase your efficiency and maximize the revenue you receive for the services you provide. And that's where I will leave it. If you have any questions at all, please feel free to contact me at the information here. It's been wonderful to be able to speak with you all today. And as I said, if you have any questions, let me know. And thank you.